Right, so three types of cartilage. Fibrous, elastic, hyaline. Properties: fibrous is resistant to compression, elastic is elastic, hyaline is mechanically resilient, somewhat elastic. Where can you find those structural differences? I'm not going to ask this. Uh, find those types of the cartilage. So elastic is in the ears and epiglottis. Fibrous is in the intervertebral discs and pubic symphysis, and elastic cartilage and hyaline cartilage everywhere else. Perichondrium, so cartilage, two layers of perichondrium, matrix is in the middle. Perichondrium is the only part that has blood vessels. Outer layer of perichondrium, the fibrous layer, resists the outward pressure. The inner layer, chondrogenic layer, contains the stem cells. Stem cells generate chondrogenic stem cells generate chondroblasts. Chondroblasts are located close to the perichondrium and they produce matrix. Chondrocytes are derived from chondroblasts. They are deep inside the matrix and they produce matrix as well. So oppositional growth of the cartilage is when chondroblasts located close to the perichondrium produce matrix. And interstitial growth is when chondrocytes located deep in the matrix, right here, deep in the matrix, expand the cartilage from within by depositing matrix from the inside. Axial appendicular skeleton. Axial skeleton, it's a skull, vertebral column, thoracic cage. Appendicular skeleton, girdles, pelvic, pectoral, and upper lower limbs. Long bone, all bones of the limbs, minus tarsals and carpals. Short bones, tarsals, carpals, patella, flat bones, ribs, sternum, bones of the cranium, irregular bones, coxal bones, vertebrae, a bunch of facial bones like mandible and maxilla. Bone functions: movement, support, storage of the minerals, storage of energy in the form of yellow bone marrow, hemopoiesis, generating of red blood cells. Bones are organs, they have multiple tissues in them. Growth arrest lines are formed when the person is malnourished or sick, and they can reveal the information about when the person was malnourished or sick. Osteoid is non-mineralized protein component of the bone consisting of collagen fibers, proteoglycans, and glycoproteins. Sacrificial bonds between collagen fibers prevent bone from prematurely fracturing. When mechanical force is applied to the bone, sacrificial bonds are destroyed, therefore dissipating the energy of the mechanical stress. Mineral that's responsible for the bone hardness is hydroxyapatite, calcium phosphate. 4 types of cells are listed here basically. Osteogenic cells function, that's a stem cell, they generate osteoblasts, they do divide, located on the bone surface. Osteoblasts produce new matrix, do not divide, located at the bone surface. Osteocytes monitor and maintain matrix, do not divide, located deep in the bone. And osteoblasts belong, so these three, one generates another. So osteogenic cells differentiate into osteoblasts, osteoblasts differentiate into osteocytes. Now osteoclasts are of completely different progeny, they derived from macrophages, do not divide, located on the bone surface, they resorb the bone. Units of the compact bone are called osteons, they consist of concentric cylindrical lamellae. In adjacent lamellae, collagen fibers run in the different directions, which provides additional resistance to twisting forces. Central canal here, it contains blood vessels and nerves. Perforating canals connect central canals and they contain blood vessels. Lacunae are empty cavities between lamellae, and in those lacunae are osteocytes. Canaliculi are small channels connecting lacunae, allowing osteocytes and the lacunae to communicate with each other. Interstitial and circumferential lamellae. Interstitial lamellae are the residues of the old osteons. The residues of old osteons. So interstitial lamellae are the residues of old osteons. Sorry for that glitch. That are located between osteons. They are a result of destruction of old osteons during the bone remodeling. Circumferential lamellae run around the entire bone, provide extra resistance to twisting. For, it should be spongy bone. For spongy bone, major structural elements are trabeculae. They do not have osteons. They don't have central canals. They do have lacunae, canaliculi, and lamellae though. The surface of the compact bone on the outside is covered by periosteum. On the inside, compact bone and the surface of the trabeculae and the spongy bone are covered with endosteum. So short, flat, irregular bones. Compact, spongy in between, red bone marrow in the spongy bone. For the long bone, epiphysis are the ends of the bone, diaphysis, the central shaft that connects epiphysis, and that shaft you can find the medullary cavity. And the long bone is the only type of a bone that has a cavity. And the medullary cavity of the long bone in kids is red bone marrow. In adults, it becomes yellow bone marrow. Red bone marrow generates blood cells, while yellow marrow is the fat storage, basically. Periosteum that covers the bone on the outside attaches it. Periosteum is attached by the Sharpie's fibers or perforating fibers. And when these fibers are destroyed or broken, damaged in some way, there is an inflammation of periosteum, which is called periostitis. You know it as a shin splints. So periosteum is the site of attachment for tendons and ligaments, same connective tissue. Types of bone markings. So what you need to know here. If I tell you tuberosity, you tell me projection. If I tell you foramen, you tell me opening. If I tell you fossa, you tell me depression. Also, you have to know what they do. Like foramen and canal and fissure will be passage. Fossa will be likely the place where the muscle is located. Tuberosity, tubercle, any kind of projection, muscle attachment. So I hope that clarifies it. Well, okay, according to my panel here, the recording is going, so let's all keep our fingers crossed. Ossification, formation of a bone. Endochondral ossification. Remember, there are two types, endochondral and intramembranous. So endochondral starts in the hyaline cartilage, intramembranous starts in the connective tissue membrane. So endochondral ossification. What you have to be able to tell me. It starts with the formation of primary ossification center in the future diaphysis of the long bone, but it starts in the cartilage. It's actually cartilage, okay? So primary ossification center forms, cartilage is eroded, and blood vessels penetrate into the what's going to be a diaphysis of the long bone. Slowly the cartilage is replaced with the bone, and medullary cavity is formed, and then secondary ossification centers are formed in the epiphysis. In the epiphysis, cartilage is replaced, but cavity is not formed. Instead, epiphyses are filled with spongy bone. There is a tiny band of cartilage between the epiphysis and diaphysis, which is going to be the growth plate, and cartilage is left on the articular surfaces. That's going to be articular cartilage. Okay? And the bones that are formed by endochondral ossification, there are multiple. You should be able to give me an example. Every long bone, endochondral ossification. Intramembranous ossification. Remember, it starts in the connective tissue membrane. You basically have an ossification center where osteoblasts start to deposit matrix, and they keep moving the the front, the line where the bone is formed, away. So some osteoblasts become trapped in the center, and when they become trapped in the center, they differentiate into osteocytes. So eventually what you end up with is that all connective tissue membrane is replaced with the spongy bone, and then through the remodeling, the outer surfaces of that new plate of the spongy bone are remodeled into the compact bone. So no cavity, all you have is 2 layers of compact bone in the end with a spongy bone in between, and the bones that are formed via intramembranous ossification are clavicles and the bones of the skull. Interstitial bone growth. Growth in length. Okay? So, as far as I understand, nobody is growing anymore in this company, you know. We stopped getting taller. But when you were getting taller, that was your interstitial bone growth. Okay? So basically what happens, and that is something, sometimes, you know, it's really, you have to imagine that. Remember we were talking about the growth plate? So you have that bone, you have a growth plate here. So in that growth plate, new layers of cartilage are formed, but the old layers of cartilage are converted. They removed and replaced with the bone. So it's like, you know, building a wooden house, expanding your house by building wooden walls, and then at some point replacing those walls made out of wood with the walls made out of stone. Just keep expanding your house. Does that make sense? Okay, good. So 5 zones. Resting zone. Chondrocytes produce matrix. That's it. That's where the cartilage actually expands. Proliferation of proliferative zones. Chondrocytes divide. There are more and more of them. So essentially proliferative and resting zone, they push the end of the bone outwards. Hypertrophic zone. Chondrocytes become larger. Calcification zone. Chondrocytes die, cartilage calcifies, and now you have calcified cartilage which with a lot of empty spots, empty cavities where chondrocytes used to be, empty lacunae. And in the ossification zone, calcified cartilage is replaced with the bone. Okay, so osteoclasts remove the cartilage, osteoblasts deposit the bone. Now when you 18, 20, 21, your growth plate closes. Basically, you stop growing. There are no more zones. Everything gets calcified and ossified, and it's it. Oppositional bone growth. Growth of the bone, kind of from the inside, growth in width, remodeling. So osteoblasts in the oppositional growth, they deposit new bone. Osteoclasts remove the old bone. Does that make sense so far? So think of it this way. Can you imagine a long bone like a humerus? So if you will start working out, seriously, resistance training, then osteoblasts will add new layers of the bone on the outside of the humerus, and osteoclasts and osteoblasts will also remodel the part of the bone that faces the medullary cavity. So your bone will become wider, like, you know, we say heavier bones. It becomes wider, but not too much heavier than it used to be. So it's like you have, well, it's going to provide a stronger support. So basically, osteoblasts add new layers, osteoclasts remove old layers. Mechanical stress in the bone remodeling determines where. My favorite example. You see I'm holding that computer pen, holding the stylus. On my middle finger, there is a bump, because that's where I'm holding pen. That's where the mechanical stress is. Does that make sense to you? You can, like, if you're right-handed, check your right middle finger. If you're left-handed, check your left middle finger. You will be able to notice that little bump. That's mechanical stress that determines where the remodeling occurs. Calcium levels. Calcium levels, they determine if it occurs or not. Calcium is more important than remodeling. So if calcium in the blood is low, there will be no remodeling. The bone will be degraded to provide enough calcium in the blood. Hormonal controls determine when it happens. Like growth and thyroid hormone. They increase the bone growth. Remodeling units consist of osteoblasts and osteoclasts. For calcium homeostasis, calcium blood levels are of the utmost importance. Hormone that controls calcium homeostasis, parathyroid hormone. So here's how it works. Imagine that your blood calcium goes down. That stimulates the release of parathyroid hormone from parathyroid gland. Parathyroid hormone does a lot of things. For our intents and purposes, we need to remember that it increases osteoclast activity. Does that make sense? So osteoclasts start to remove more bone. They deliver that calcium into the blood, and calcium in the blood is restored. Okay? Now, for a second, let me ask you this. Imagine that you have that you have a patient who has cancer, and that cancer affects the patient's parathyroid gland, and his parathyroid gland produces a lot of parathyroid hormone, a lot. What's going to happen to the calcium levels in the blood of that patient? Huh? Michelle, you're unmuted. You can say.
Oh, am I?
Yeah, it's fine.
Oh, am I?
What's going to happen to... They're going to go...
Would it go up?
Now you muted yourself.
Oh.
They're going to go up. Oh. Right. What's going to happen to the bones in that patient? How are they going to look?
Brittle.
Mm-hmm. Yep, because PTH remove all the calcium. Does that make sense? That's an actual clinical, that can be a clinical condition. Okay, we got this. So osteoclasts essentially remove calcium from the bones. Calcitonin. Calcitonin is a bit controversial for our intents and purposes. We can say calcitonin reduces blood calcium. So let me just remove all that chicken scratch. So for calcitonin, this is what's going to happen. If your blood calcium is high, that stimulates calcitonin production. That leads to the deposition of calcium in the bones, and calcium levels will go down. Other sources for calcium replenishment. Your kidneys will start to excrete less. They will save calcium. And your intestine will start to absorb more. Hypocalcemia. General idea in hypocalcemia, you have everything irritable. Muscles can do cramps, seizures. People become irritable like on the nervous level. You see? So that's hypocalcemia. Hypercalcemia, it's opposite. Depression, muscle weakness, arrhythmias in the heart, sleepiness. Does that make sense? Lethargy. Okay. Growth hormone stimulates bone growth. Thyroid hormone stimulates protein synthesis, promotes bone growth. Parathyroid hormone is... Jesus. Parathyroid hormone inhibits the bone growth, prevents it because it depletes calcium from the bone. Calcitonin stimulates bone growth. Estrogen and testosterone significantly stimulate bone density, and they stimulate bone growth in the beginning of the puberty, but the spike of testosterone and estrogen at the end of puberty actually stops the growth of the bone. Types of fractures. Let me clarify it. You see this 3 pairs. That's what you got to know. I'm not going to ask green stick. I'm not going to ask comminuted, transverse, oblique. No. Am I clear? I can ask you like about some differences, but yeah. Know what they are, know what the difference is on a very basic level. We're not physicians here, so ask complete and incomplete. You tell me complete, broken all the way through, incomplete is not broken all the way through. I hope we're good. Okay, fracture repair. That's kind of messy here. They're like 2 things repeated. It's just the same question. First stage, hematoma, right? Hematoma is formed, blood clots, traps all the crap in one place, and then through the capillaries, fibroblasts migrate to the site of the injury, and fibroblasts start to produce collagen. Phagocytes clear up the debris. Osteoblasts and chondroblasts start to deposit cartilage in the bone. Second stage is called, as you remember, fibrocartilaginous callus, because at this point it's mostly connective tissue and the cartilage. Eventually osteoblasts deposit enough spongy bone, and that is a bony callus. We good so far? And then in the 4th stage, basically you get the bone remodeling, and the outside, like if that bulb was the site of a fracture, here on the outside, spongy bone is remodeled into the compact bone. So why does the repaired bone have the same shape as the bone before the fracture? The answer is simple. If you fracture your humerus and eventually it grows, the fracture is healed, your humerus keeps experiencing the same mechanical stressors. You do all the same stuff with your arms. Same mechanical stressors, same shape. Osteomalacia, calcium deficit in the diet of adults, or vitamin D deficit in the diet of the children. Rickets, that's same as osteomalacia, but in kids. Am I clear? Osteomalacia adults, rickets kids. Symptoms: bones are soft, can bend, bone deformities ensue. Now, those are main signs and features. Osteoporosis, calcium resorption outpaces the calcium deposition. So let's clarify. Osteoporosis can happen if you have, for instance, too much parathyroid hormone. That happens, but it's rare. The main issue with osteoporosis is that it affects females after the menopause, because estrogen levels decline and calcium is not deposited in the bones as effectively. In men, osteoporosis is not as manifested as in females, because in males testosterone declines much slower. So, what I wanted to say. Yeah, so risk factors. Female, postmenopausal, so age is a huge risk factor. Caucasian, small body shape, like smaller women are at the high risk. Sedentary lifestyle, alcohol consumption, smoking, and really big problem, consumption of the soft drinks, because they are very acidic and they remove calcium from the bones. The drug that can make men more susceptible to this disease are various androgen inhibitors. When men have prostate cancer, they receive androgen inhibitors, which basically prevent the effects of normal men androgens, and that will reduce the effect of androgens on the calcium deposition. There will be less calcium deposited in the bone. Well, yeah, we discussed it. What makes women more susceptible? Menopause, Behçet's disease, haphazard accumulation of the bone. Just Too much of osteoblast and osteoclast activity. Bones are brittle, poorly formed. Cause is unknown. Usually manifested in the hips and in the head, the cranium. Best prevention strategies to avoid osteoporosis. Exercise, eat a lot of calcium, don't drink soft drinks, don't smoke. Weight-bearing exercise. When you lift, your bones becomes, bone density increases, essentially creating a savings account. Okay? So weight-bearing exercise increases the bone density. Hormone replacement therapy for osteoporosis. Dangerous because it can cause cancer. It can lead to cancer. Biphosphonate actions. Biphosphonate causes the apoptosis of osteoclasts, essentially preventing osteoclast activity. And denosumab also targets osteoclasts into the apoptosis. It's highly specific. Estrogen receptor agonists. They act specifically, stimulate estrogen receptors on the bone, but not on other organs like breasts or uterus. So it's kind of selective way to stimulate the deposition of calcium in the bones without exposing the patient to the risk of developing uterine cancer or breast cancer or ovarian cancer for that matter. Joints, articulation of two bones. 3 types of joints based on mobility. Synarthrosis, immobile. Amphiarthrosis, partially mobile. And diarthrosis, freely mobile. So, sutures, synarthrotic joint, radioulnar joint, joint between the radius and the ulna. Amphiarthrotic joint, wrists, interphalangeal joints, diarthrotic, freely movable. Structure, fibrous joints connected by the connective tissue, cartilaginous joints connected by cartilage, and synovial joints. There is a synovial cavity. Only diarthrotic joints, only freely movable joints in the human body are synovial joints, no exceptions. All diarthrotic joints are synovial, all synovial joints are diarthrotic. Okay? 3 types of fibrous joints. Sutures, syndesmosis, and gymphosis. Know where they are. How movable are they? Sutures, immovable. Syndesmosis depends. That's movable joint, but say tibiofibular joint is not. Gymphosis between your teeth and your jaw, not movable. 2 types of cartilaginous joints. Synchondrosis and symphysis. Synchondrotic joints. Costal cartilage, not movable. Symphysis, between your vertebral discs or between the hip bones, partially movable. Synovial joint, what gave them their name? Synovial cavity. Structural features. You have articulating ends. They are enclosed in a cavity. Ends are covered with articular cartilage. Cavity is formed by the fibrous capsule. That capsule may or may not contain ligaments. Sometimes it does, sometimes it doesn't. They can be extracapsular ligaments. Okay? Ligaments can be capsular that form the capsule, and they can be intracapsular inside of the capsule. We're going to provide some examples. Inside of the capsule, on the inner wall, there is a synovial membrane that produces viscous synovial fluid. Synovial fluid lubricates the ends of the joint. Okay, those are kind of main. Nerves, blood vessels, yeah, that we got it. Now, a few structures that you can find in some synovial joints. Bursae, fat pad. If you ever did something and you were standing on your knees for an extended period of time, and then you stand up and they hurt, and they hurt for a while, you probably have transient bursitis. Suprapatellar bursa just got inflamed. Sorry, that's a fat, no, it's not a bursa. That's a fat pad. Bursa is different. Bursa is, I just mixed it up. So fatty pad, that's what we just discussed. Okay? Now, what the bursa is a different ball game. Bursa is basically a bag made of synovial membrane. It's a sac with a synovial fluid inside, and it rolls like a berry. So if you have a ligament and a bone and they move against each other, between them will be a bursa. So that water bottle represents a bursa. Does that make sense? Tendon sheath is basically extended bursa. It surrounds the tendon and works the same way. It rolls like a berry. 3 factors that stabilize synovial joint. Know it as 1, 2, 3. Least important, shape of articular surfaces. More important, number of ligaments and, what they connect and strength of ligaments. Most important factor stabilizing the joint, muscles that cross it. Does that make sense? Let me give you some examples. TMJ, is it a stable joint? It is not, because muscles that cross it are weak. They're small and weak. Your, say, knee joint or, hip joint, is it stable joint? It is, because muscles that cross it are very strong, and there are many of them. You see that? The stronger the muscles, more stable the joint is. You can train your muscles and stabilize the joint more. Six types of the synovial joint: condylar, saddle, hinge, plane, condylar, saddle, hinge, plane, ball and socket, and pivot. Okay, there's 6 types based on the structure, based on the type of movement. Is that clear? Pressing question. Do you need to know which joint is which for the entire body? What do you think? No. The only joints that I can ask are in the study guide. So that makes it, I'm trying to remember my own study guide, so it makes, correct me if I'm wrong, because it's somewhere down there. Hip, knee, elbow, shoulder, TMJ. Is that right? Yeah, I think that's it. So basically what I'm asking, jaw, 2 types of joints. There is a hinge joint, right? And there is a plane joint, gliding motion. Elbow, hinge, shoulder, ball and socket. Knee, 2 hinge joints and 1 gliding. Hip, ball and socket. Are we clear so far? Okay. So essentially, when I ask you, like, the type of the joint based on the number of axes, tell me about the elbow. So you tell me, elbow is a hinge joint, uniaxial. Does that make sense? Tell me about the jaw. Jaw is 2 joints, the hinge one, uniaxial. The plane joint, non-axial. We good so far? The reason why I'm looking this way, looking this way, is because that's where your faces are. I'm going to move you over here. Okay, movements. Can you see me? So I'm going to give you some. So movements, you should be able to tell me for those joints the movements that they can produce. So let's use elbow. Angular movements, flexion, extension. Does that make sense? Now, For shoulder, that will be flexion, that will be extension. That will be flexion, that will be extension. Specific movements in the coronal plane. Abduction, adduction. I remove it from the body, I abduct it, and I add it to the body. I adduct. Circumduction. Can you see my arm? Circumduction. Rotation. Also, you can do it in a shoulder. I rotate my shoulder. There is some limited rotation in the shoulder. Okay, it's better. This is supination, pronation. Supination, pronation. Does that make sense? Inversion and eversion, outer edge of your feet, inner edge of your feet. I'm not showing it to you. I'm not jumping on the table, sorry. Dorsiflexion, plantar flexion. If that's my foot, plantar flexion, dorsiflexion. Plantar flexion, dorsiflexion. Elevation and depression. Elevation, depression. First was depression, that's elevation. Protraction, retraction, moving your jaw forward and backwards. Opposition, okay? We got it? Awesome. Individual joints in the knee, 3. Patellofemoral, lateral tibiofemoral, medial tibiofemoral. Movements, flexion and extension, a small tad of rotation. I wouldn't be too picky if you're not mentioning rotation, it's fine. 3 ligaments that form anterior wall, medial and lateral patellar retinacula and patellar ligament. Joint hyperextension prevented by tibial collateral, fibular collateral, oblique and arcuate popliteal. Muscle tendon reinforces the joint. You can tell me that tendons of the quadriceps muscles and hamstrings reinforce the knee joint. Menisci improve the fit between the joints, between the femur and the tibia, and reduce wear and tear. But anterior posterior displacement of the knee, anterior cruciate and posterior cruciate, they are intracapsular. Lateral blow to the knee, first tibial collateral ligament, then anterior cruciate ligament, then meniscus. Okay, those are 3 classical structures. Shoulder joint, ball and socket, movements, a bit of rotation, flexion, extension, abduction, adduction, circumduction. It is not stable, second most easily dislocated, most freely moving joint in the human body. Major reinforcing ligaments, you need to know 2 coracohumeral and glenohumeral ligaments, so there are not many of them, which means it's not too stable. And muscle tendons, rotator cuff muscles, mostly stabilize the joint. Rotator cuff muscles are relatively weak, so joint is not stable. Elbow joint, flexion and extension, it's a hinged joint, uniaxial. Muscle tendons, biceps and triceps. I don't know why it's 2 here. Probably I ask about ligaments. So ligaments. Radial collateral, ulnar collateral, annular ligament. Hip joint, ball and socket, less stable than the shoulder. Okay? Sorry, more stable than the shoulder. What am I saying? More stable than the shoulder, but less mobile. We good so far? Movements, bit of a small bit of a rotation, adduction, abduction, flexion, extension, hyperextension. Okay, not elbow, that's a typo, it's a hip joint. So 4 ligaments that reinforce hip joint. Ligamentum teres, that connects the head of the femur to the acetabulum. Pubofemoral, iliofemoral, ischiofemoral ligaments. Acetabular labrum is the ridge of the hyaline cartilage that improves the feet and kind of grabs onto the head of the femur. Temporomandibular, which movements does temporomandibular joint produce? Depression, elevation, protraction, retraction, gliding, lateral gliding. Stability, least stable joints in the human body. Cartilage and ligaments repair slowly because they poorly vascularized. My own experience, I had a small ligament damage, and the physician said, "Yeah, we can fix it. We can do a surgery and stitch it up." And I asked, how long am I going to be in a cast? And they said 6 months. I said, "No, thank you very much. It's going to heal itself. It's fine." Main method of treatment of cartilage tears: reduction, arthroscopic surgery, removing fragments of the cartilage. If we're talking about meniscus, so the problem with meniscus, every time you remove a piece, it reduces the stability of the knee joint, increasing the chance for further injury. So basically, you progressively lose meniscus, and eventually it is gone. Okay. So when meniscus is gone, ends of the bones, tibia and femur, start to rub against each other, and that leads to osteoarthritis. Cartilage tears, graft, stitching them up, just reduce and let them heal. Not the cartilage, sorry, sprains. That's a sprains. Stitch them up. That's one approach. Reduce, so put it in a cast so it heals, or replace with a graft. Sprain is the tear in the ligament. Ligaments can be transplanted because they are poorly vascularized. Anything that is poorly vascularized can be fairly easily transplanted. You can get a ligament from a cow as a replacement, as a graft. Luxation is dislocation of a joint. It's often accompanied by the tears and sprains. Subluxation is partial dislocation. Bursitis, inflammation of a bursa. It can be caused by pressure or blow. Tendinitis, inflammation of a tendon, overuse, like a golf elbow, tennis elbow. Arthritis is inflammation of a joint. It's a degenerative disease of a joint. 3 types: osteoarthritis, rheumatoid arthritis, gouty arthritis. Symptoms: pain in swelling of a joint, and eventually fusion of the bones. Osteoarthritis. Wear and tear. Most likely cause is wear and tear. We just rub on the articular cartilage, it eventually degrades, and it usually develops in the elderly. Ends of the bone start to rub against each other, get inflamed, start to fuse with each other. So that's it, just wear and tear. Dietary supplements are not effective. Rheumatoid arthritis, autoimmune disease. Immune system attacks synovial membrane in the joint, leading to inflammation of the synovial membrane. That's synoviitis. Then it progresses, forming connective tissue, the scar tissue between the ends of the bone, and that scar tissue, that's fibrous ankylosis. Eventually that scar tissue, connective tissue, is replaced with the bony tissue, and that is bony ankylosis. If rheumatoid arthritis is left untreated, it ultimately fuses the bones in the joint, and joint completely loses the mobility. Treatment options: immunosuppressants, non-steroidal anti-inflammatory drugs, painkillers, capsaicin creams to reduce the pain. Gouty arthritis, accumulation of uric acid in the joints, which leads to the inflammation. Males are mostly affected. Usually it's in a feet. A basic mechanism. Yeah, if disease is not treated, bones and the joint fuse. Lyme disease infection caused by a bacteria transmitted by tick. Bacteria goes in the joints and leads to the acute arthritis. Okay, that will be it for the recording.